It's not a complete accident that I'm here talking on this topic. I was last in Dublin in 1998. In 1998, I was still in training. I did my cardiology training in San Francisco. And I had done a research project on looking at the outcome of hypoplastic left heart syndrome amongst patients who had a prenatal diagnosis and those that didn't. And patients who are diagnosed with hypoplastic left heart after birth can become very, very sick and even not survive if they don't get to the hospital in time. And of course, as we know, prenatal diagnosis has evolved and obviously is more common now. So that's why I start out from fetal diagnosis. So at first, we had to make the diagnosis and improve outcome. But we now have moved on to fetal therapy for a select group of these patients. So this was the data that I presented in 1998 at the European Pediatric Cardiology meeting. Dr. Desmond Duff was the chief of pediatric cardiology at the time, and he was kind enough to accept our research at that meeting. Basically, what we had showed how you can stabilize these patients if the diagnosis was made before birth and they had significantly improved outcome. This was a short study over about a 5-year period in San Francisco. And treatment for hypoplastic left heart has certainly improved over the years, but it is still a very, very serious cardiac defect with quite guarded medium and certainly long-term outcome. And certainly long-term we don't know because the oldest survivor for neonatal surgery now is only around 30 years old. What we showed in the study is really how we could make those patients more stable if they were diagnosed before birth. This is just looking at some of their acid-base data. Anyway, I just wanted to give you the background on how we came from studying diagnosis to then moving on to therapy in some of these patients. And I'm going to start off with an example of what exactly we're talking about here. So I know that we have a diverse audience here from parents and families and medical practitioners in different specialties, some obstetricians, maybe cardiologists as well. So this is what you'd call a relatively normal-looking 4-chamber view on the fetal heart. Now, this patient did have mild aortic valve narrowing or stenosis at the time, and a very astute cardiologist or an obstetrician who were following this patient then saw the patient back very soon, because one of the problems with aortic stenosis in a 20-week fetus is that it can get significantly worse quite quickly. This same patient, seen 2 weeks later, had severe left ventricular dilation and dysfunction and an almost completely blocked aortic valve. And the way I like to describe this to parents and people are much more aware of coronary artery disease and heart attacks, people having myocardial infarcts. In the fetus, this is almost the equivalent, where the blood flow to the heart muscle is being compromised and damage to the myocardium ensues, the heart muscle, if you don't get enough blood and oxygen and nutrition to your heart muscle, and it's working harder than normal. And so it's almost the equivalent of the fetus having a heart attack. It's similar to that. And we had made these observations over the years, us and other people. In this particular case, the patient was fortunate enough to come to Boston Children's at very short order. Here's the stenotic flow jet, this blue jet, across the valve. And here is a picture of our needle going into the baby's heart. And really direct puncture under ultrasound guidance, similar to an amniocentesis technique, into the fetal heart. And then a wire, you can see the little wire here, is advanced across the valve. You can see this little white line here as the wire is advanced across the valve. And then we take just a regular coronary artery balloon dilation catheter. I'm sure people in this room are aware of people having coronary stents or coronary angioplasty. It's the same balloon, except that a fetal heart valve is about the same size as an adult coronary, and so we use the same balloon. We inflate the balloon and open up the valve. And this particular patient was lucky enough, the function recovered significantly. You can see it looks like the first picture. And this baby, this is just an example, at a few years of age, has a very well-functioning left ventricle. And in this particular case, we really think that we averted progression. This baby was headed towards hypoplastic left heart, and in this particular case, we managed to get there just in time, open the valve, and improve flow and function through this valve. And this baby is now probably about 6 or 7 years old. Now, of course, this is challenging and doesn't happen in every case, and I'll give you an example. This is another patient, quite similar, with a dilated ventricle, left ventricle here. You can see this bright stuff here. It's what we call endocardial fibroelastosis, or scar tissue. So if you get enough damage to the heart muscle, you get this bright appearance. And the natural history of this, if you leave these alone, what happens is, in late gestation, this is the right ventricle, this is the left ventricle. The left ventricle essentially shrinks or just stops growing. And that's what we call hypoplastic left heart. Of course, in this case, we did try and intervene. And we opened up the valve, and the procedure went perfectly. But the heart didn't respond and still ended up with hypoplastic left heart. So this is the challenge that we're facing today, is how do we get to patients earlier? How do we have them diagnosed and referred earlier? And how do we better select patients who really will respond positively to this procedure, and at the same time select the patients who we think it's probably futile and that we're putting the mother and the baby at some risk doing a procedure when there may not be benefit. And that's really the challenge of our research today. So now I've sort of given you the end of the story, and now I'm going to tell you how we got there. Actually, this is just, again, summarizing our most recent publication on this topic, where we looked at the first 100 patients. And again, we didn't manage to cure all of them or prevent hypoplastic left heart in all of them. And certainly, when they're born, they still need treatment, often a valve replacement, often the aortic valve to be replaced because it's abnormal. But what we did show is that at least in half the patients in whom we were able to open up the valve, we averted progression to hypoplastic left heart. And so our challenge is to try and improve on that. What we did show was something very simple and something that I guess in a study we like to see is survival benefit. That those patients in whom we prevented hypoplastic left heart actually had a greater survival. So that's one important step, is that we did show an improvement. So what I'll talk about is the rationale and why we do this, the evolution of how we got there, the techniques, and show some examples and maybe talk about what we're going to do in the future. Now, in the field of pediatric cardiology, we've actually come a long way in treating many serious heart defects. We managed to close holes in the heart, VSDs, ASDs. Sometimes patients need holes created to improve their heart function. We're able to increase blood flow in the heart, decrease blood flow if needed, and do complex repairs such as the arterial switch for transposition. The problem right now that we're facing, we can replace valves, we can enlarge vessels, but the heart muscle cannot be replaced. That's something that is very important to preserve the function of the heart muscle. And of course, everybody's heard the word stem cells and how that might be the future and how that might be a way to improve the function of many organs. Certainly, we're not quite at that point yet where we're using them in a clinical setting, but it may hold some promise in the future. In terms of fetal therapy, it is a wide open field. There are a lot of interesting things going on, and of course we have to be very cautious. Right now, there are several well-accepted fetal therapies. Blood transfusions for fetal anemia, often an immune reaction that causes anemia in the fetus. Twin-twin transfusion syndrome certainly evolved, and now laser therapy is quite common in standard therapy. And of course, in my field, in cardiology, we very commonly give medication to the mother, which then crosses the placenta and treats the rhythm, usually a fast heart rhythm in the fetus, and that works very, very well. A lot of other fetal therapies, fetal surgery, still in the phase of trying to find out which is the best way to do things, and certainly the direction is going from more invasive open surgery now towards minimally invasive image-guided endoscopic surgery. Now, in fetal cardiology, as opposed to other open surgery, there are a few differences. Our procedures are not open fetal surgery. We're not opening the mother's abdomen or the uterus. And we're also mostly not treating lethal disease. What we're trying to do is optimize the heart function, improve things, but often it's not lethal, at least at birth. Perhaps hypoplastic left heart with an intact atrial septum is a highly lethal condition. I'll talk about that a little later on. And unlike other fetal surgery, we are actually operating on the heart, whereas with other fetal surgeries, they're relying on the heart to provide the circulation. And importantly, we have not performed a randomized trial on this therapy because when you start something, you start to, tiptoe forward and make small steps, and then you sort of get ahead of yourself, and then at some point you have to decide to do a randomized trial, which has been done in many other forms of fetal therapy, and that's always a possibility in our field, but we have not done that yet. The big picture here, the goal of why we do this at all is to try and prevent, so we're trying to promote growth of the cardiac ventricles and promote improvement in function and prevent what we call a univentricular circulation, or a circulation in the heart where there's just one main pumping chamber. We're trying to get back to 2 pumping chambers, which is the way it's supposed to be. And in some cases, we're trying to just improve survival, hypoplastic left heart. It's obviously a much broader field, but I'm going to focus mostly on aortic stenosis here. So why do we do this at all? We do have treatment for hypoplastic left heart, surgical treatment. It's usually 3 stages initially, and then many patients will need a heart transplant later on. So why do we do this at all? What's wrong with current therapy? Well, if you look at the current data in terms of survival of babies for hypoplastic left heart, 2 recent studies, one from our institution and one a national study in the United States, show that by age 3 to 4 years, so that's when they are through their first 3 surgeries, the survival is only about 67%. So 1 out of 3 babies doesn't survive to that point. And of course, by most standards, that's a very, very high mortality. Certainly most other heart defects have much better survival. And of course, that's short-term survival. That's only up to 4 years of age. Longer term, many of these patients, unless we come up with a new therapy, are going to probably need a heart transplant when they get into their 2nd, 3rd, and 4th decade of life. And already we don't have enough donors for heart transplant, and if we have these patients growing up with single ventricles into adulthood, there's going to be a further demand for heart transplant. So we're going to have to come up in a subgroup of these patients with some other therapy. Our first ever fetal procedure was done in the year 2000, so about 2 years after I presented my study here in Dublin, where we hadn't even begun that, we were thinking about it. In that patient, the procedure was actually unsuccessful. We were not able to open the valve, and that patient is now 14 years old. I guess I should do the math now, and she's probably 15 years old, and has had her 3 stages of surgery, and she has hypoplastic left heart syndrome. The second procedure was done 18 months later, and that was our first, what we call, technically successful procedure. We actually opened the valve, but also we got lucky, and that patient really responded the way we wanted, and today is now 14 years old, and I have to update those numbers because it's in 2016 now, and is actually doing very well and has 2 pumping chambers. And you can imagine counseling the second patient about this procedure, and the parents saying to us, well, doctor, have you ever done this before? And we had to say, yes, we've done it before, but we failed miserably the first time. And they said, well, it makes sense to us. The theory behind what you're doing makes some sense. Maybe we should try it again. And I think that's where we have to really appreciate and thank our patients for taking the risk with us. When we're doing these essentially experimental procedures and trying to improve things, we're putting our patients at some risk, and they're putting themselves in harm's way. And of course, in this case, you have 2 patients. You have the mother and the fetus. And because of these brave women, we're able to push the field forward and try and understand these diseases and try and improve things. And so in particular, these 2 patients really led the way for us. The people who really started this, who came up with the idea initially, were actually in London at Guy's Hospital. That's Lindsay Allen, who's a fetal cardiologist, Mike Tynan, who's an interventional catheter cardiologist, and Darrell Maxwell, who was the obstetrician, maternal fetal medicine doctor. And these 3 people in the late 1980s, Lindsay Allen in particular, described this phenomenon of aortic stenosis developing hypoplastic left heart syndrome. And then they went ahead. It was probably the early days of fetal procedures, but they went ahead and did the first few procedures with some technical success. Of course, they had ultrasound machines that are not as good as today. They had equipment that is not as good as today. But certainly, they were right in concept. And then, shortly after that, the team disbanded for all sorts of reasons, and the whole sort of idea of the procedure came to an abrupt halt. And then there were a few other procedures around the world, and then we picked this up again in the year 2000, so sort of 10 years later. Hypoplastic left heart syndrome, I'm sure you've all heard of the term and what that is. It's not just one disease. It's like saying all kidney diseases are the same, all brain disease. It's not really all the same. There are many different ways that a baby can develop hypoplastic left heart. Every piece of the left heart can have a problem with it. The one that we're really focused on is what we call aortic valve stenosis with evolving hypoplastic left heart. And this is really where the aortic valve problem is the main one. The aortic valve gets progressively narrowed or blocked, and the blood flow diminishes and causes increased work and stress on the heart muscle, and then damage ensues. Not only that, but because of the uniqueness of the fetal circulation, where you have these holes communicating with the placenta, blood is actually directed away from the left heart, which then leads to the heart not growing. And this is what those patients typically look like. Again, the dilated ventricle. I'm going to show you these pictures over and over again because they all kind of look similar. You can see the heart's not squeezing very well. And here you see blue and you see red. This is flow in the pulmonary artery and the aortic arch. And the blood is actually flowing backwards in the aortic arch in the circulation. And that's usually a very bad sign. And you get abnormal flow patterns. Now, in the field of pediatrics, pediatricians love to say that our patients are not just small adults. They're very different. Their organs are still developing. They respond differently. And I think the same in the fetus. Of course, the fetus develops for 9 months and, of course, is also prone to respond differently to insults that occur in utero, whether it be biologic or anatomic or physiologic insults. And I can say that we don't really understand all of this. We're really in the early phases of trying to understand this. But we think that the heart muscle in the fetus responds very differently than if you were 50 years old. That it's more sensitive, potentially, to changing and having a different sort of damage reaction or scarring reaction. For example, if I developed aortic stenosis now, I wouldn't get hypoplastic left heart. My heart muscle would get thick. I would be short of breath. I wouldn't be able to exercise. But in the fetus, it's different. The heart muscle gets damaged, and blood flows away from the left heart, and it actually shrinks or stops growing. But the other thing that's interesting, of course, is that there may also be potential for recovery, in that the fetal tissue may be more pliable, more plastic, and more have the ability to recover. And there's some research on fetal tissue healing, and this may be part of that as well. This graph just shows how we look at aortic stenosis. If you have aortic stenosis that's extremely mild in early gestation, it can stay mild. The heart can tolerate that, and you may be born with neonatal aortic stenosis and a good-sized ventricle. But if you have more severe stenosis in early gestation, by the time you're born, you may have, or highly likely to have, hypoplastic left heart. And of course, in between are variations of this. So we're mostly interested in these patients that have severe aortic stenosis in early gestation, and we're trying to avert this progression to hypoplastic left heart. What this usually looks like is you have a normal-sized or enlarged ventricle in early gestation, and by the time the fetus is in late gestation, the heart has shrunk. What happens is, here's your left ventricle, your right ventricle. As this valve gets more narrowed, here are the coronary arteries. The flow to the coronaries may not be normal, and the blood has to go from the pulmonary artery, ductus arteriosus, and retrograde down the arch into the coronary arteries. That's the flow reversal in the circulation that I was showing you. So this has been an evolving story, and the first thing when you come up with a fetal therapy or any kind of therapy, you need to know what the natural history of this disease is. Are we treating something that doesn't need to be treated, potentially? Because it still is a relatively controversial field. But it turns out that there are several publications, starting with Lindsay Allen, the woman I showed you in that picture, who was the first one to describe this phenomenon, followed by another study, again looking here how the growth of the ventricle is basically flat lines or static during gestation, and And this is another one from London, same hospital, a little bit later, John Simpson and Gurleen Charlin, two well-known fetal cardiologists, describing the same thing. And then our group did the same thing, looking a little bit more in detail at both the anatomy and physiology of this disease. So there is literature out there showing the natural history of this phenomenon, and that's really what led us to try the therapy. There was a paper written on the early series, again, showing that it could be done, but with very marginal results. Now, to take a step back, when you start to embark on something as complicated as this, again, you have two patients involved here. The thing that's paramount, of course, is maternal safety here, and that really goes for all of these fetal procedures that are performed now of different types. And that's the first thing that we have to consider. The mothers have to be as healthy as possible. And of course, the postnatal results for hypoplastic left heart are improving. It's not like we have no options for these patients, but they're not the best option possible in some cases. There's also an experience of radical change in our field, as there are in many medical specialties. Many of you have heard of transposition of the great arteries. The old operation that was started in the 1960s was called the Senning or the mustard procedure, where they would switch the blood flow in the atria and the upper chambers of the heart. And then in the early 1980s, starting out in Brazil, they started doing what's called the arterial switch, where they would actually switch the great arteries, the aorta and the pulmonary artery, and a little bit more complicated operation. And they went from having a 90% survival with the old operation to a 90% mortality with the new operation. And this lasted for a couple of years. I wasn't doing cardiology at that time, but I've heard the stories from my colleagues about how difficult it was at the time, where you had patients who were surviving and suddenly they had a new operation which seemed much better, but the patients were not surviving. Now today the survival for this new operation is 99%, and of course it is much better, but there was definitely that transition period that was very, very difficult for, of course, the parents who lost their children and the people in the field. And we're trying to do something big here, which is try and take a patient who was destined to have one chamber and go back to what's normal, 2 chambers. The other problem is that, unlike many disease models, we don't have an animal model that we can test many of our hypotheses on. This historic picture is a picture of a technique called cross-circulation. In the 1950s in Minnesota, Dr. Walton Lillehei was one of the pioneering cardiac surgeons who, you've all heard of a cardiac bypass machine. When you do, not coronary bypass, but the machine's called a bypass machine or a mechanical support. When you're doing heart surgery and you have to stop the heart, you need a mechanical machine to pump the blood round and round while you're doing surgery. And Dr. Lillehei came up with this technique where he would actually use the parent as the bypass machine. So they would hook up these large IV cannulas between the baby and the parent and use the parent's circulation to pump the blood around while they were doing heart surgery. And this was the beginning of cardiac bypass. And apparently he presented this at a meeting and someone congratulated him on a procedure that had a potential 200% mortality, which is true. I don't know if they ever lost a parent during this procedure, but very shortly after that, they developed the mechanical machine, and today it's standard to perform open heart surgery with these machines. But all these things start somewhere. Now, in a way, we're doing something similar, not as radical as that, but we, of course, have 2 patients. We have the mother and we have the fetus, and so here are these pictures side by side, what they were doing before, and now here's a picture of the mother's abdomen, and a needle going in and somebody trying to put a wire through. And that's basically what the procedure looks like on the outside. It looks just like an amniocentesis. And the way we do this is a needle stuck under ultrasound guidance by our obstetrician. We have a very skilled group of colleagues who perform these procedures with our cardiac team. And I would say that the obstetrician or maternal fetal medicine person is really the most important person in this procedure, because it's positioning the baby, getting the needle in the right place that is really the most important. It's a 19-gauge needle. To give you a perspective on that, an amniocentesis needle, which you'd be familiar with, is about 22 gauge. It's smaller than that, and those small IVs you put in premature neonates are 24 gauge, those tiny ones. It has about a 1 millimeter internal diameter, and then we use the coronary artery balloon for this procedure. This is just another example of the same thing. You can see the needle. This is an ultrasound of the needle going into the heart over here. You can see the dilated left ventricle here. This is a more recent procedure. And again, the wire crossing the valve and the balloon being inflated across the valve to tear the valve open. And then we like to see color flow across the valve. This is one of the earlier ones we've done. We've done this as early as 19 weeks. This is a 20-week fetus. And you can see these are centimeter marks here. So this whole left ventricle here, which is enlarged from normal, is about 15 millimeters, small. Again, you can see here the same thing. You see the balloon being inflated here. So we can do this as early as certainly 19 or 20 weeks. And this is what it looks like pre. You see the small jet of flow across the valve, and we like to see a nice broad jet after the procedure. And what we hope to achieve is this, a well-functioning ventricle. But not all patients, as I showed you, end up like this. This is an example of a patient who unfortunately came to us too late. Again, a patient with dysfunction, aortic stenosis, and this mother was told that, don't worry, your baby will be fine. We'll treat this baby after birth. The mother was, like most patients these days, the first thing they do is they go on the internet and they type in the diagnosis and they find something. They found us. Unfortunately, she came to us 3 weeks later, and by then, the heart had already started to shrink. You can see it's smaller. The stenosis was worse. And we performed the procedure, hoping we could still save this heart. But unfortunately, the baby was born, and the left ventricle, you can see the bright tissue here, was just not quite big enough to do the job on its own, and the baby needed surgery for hypoplastic left heart. Now, had we got to the patient still at this stage, maybe we could have salvaged the heart. So you're probably thinking to yourself, this sounds like a pretty dangerous thing to do, to stick a needle in a fetal heart. Bad things have got to happen. And the truth is that is true. We do have complications, and we also, like in many medical procedures, are able to deal with the complications. The most common thing that we see is bradycardia and dysfunction. So if you stick, many of you do fetal ultrasound here. Sometimes when you're just scanning the baby, the fetal heart can slow. These babies are very sensitive to touch. But in here, you're actually sticking a needle in the heart, and we see slowing of the heartbeat. And you can see our obstetrician shaking or trying to perform CPR through the mother's abdomen to get this heart started. But then what we do is we use a technique that's been used before. I don't know if you guys saw the movie Pulp Fiction. Remember that scene where John Travolta finds his boss's wife unconscious from I think a heroin overdose or something, and he performs direct intracardiac puncture and resuscitation. And so this technique of resuscitation, we actually borrowed from this, and we use the same technique to resuscitate our patients. In fact, what we do is we stick a smaller needle back into the heart, and we inject either atropine or epinephrine to get the heart started again. And usually we do this very quickly. We don't wait. And within a few seconds or a few minutes, the heart starts beating again. This happens in cardiac surgery as well. When they finish with the operation, you always see on TV how they take the paddles and they have to kickstart the heart. It's kind of similar to that. The other thing that we see, a very common problem after birth, when you do a balloon dilation on a newborn baby with aortic valve stenosis, is they can get aortic valve regurgitation or leakage because you've damaged the valve. And that's often a surgical emergency. And this has been one of the most fascinating things that we've learned from this, is what we found is that when we create aortic valve leakage or regurgitation, we've damaged the valve in the fetus is able to heal the valve and repair the valve. The tissue is so pliable and plastic, and you have rapidly dividing cells, that we think that the fetal tissue is actually able to heal itself. And I can show you some examples of that where, in this case, this blue jet is basically free aortic regurgitation after we did the balloon procedure. And this baby, by the time they were born, had zero. This is just forward flow on the ultrasound with no regurgitation. And we've seen this over and over again. And that's been really fascinating to us, and we're in the process of formally studying this now. And this may unlock some information for us in terms of how tissue is able to heal itself. You know, there's a lot of hype out there and a lot of research on using tissue for healing, and of course we always get back to stem cells and how that may have potential. There are also some unique things about the fetus, why they may be able to tolerate this better. The fetus is very resilient and can tolerate a lot of stress. And it may be that the low blood pressure or low systemic resistance because of the placenta may reduce the amount of regurgitation and stress on the valve. And of course, you have your right ventricle, the other side of the heart, pumping the circulation while the left side of the heart is healing. So the question then is, does it work? Is this really all worth all this trouble? It's obviously a lot of work involved for a lot of people here, and obviously the patient has to undergo these procedures. And have we done enough to make a difference, and are we doing better? So like everything in these very complicated medical fields, and certainly in some of these more experimental therapies, it's slow going and it's hard and tedious work. And you can look at your data any way you want. You can look at it positively and negatively. And one of my favorite statistical slides is this one. During the World Cup football in 2010, this is a real headline from the New York Post when the United States played England, and the headline was USA wins 1-1, which really, did really count as a win. I'm sure in the British newspapers it was England loses 1-1. And but that's in a way how we look at our data. We have to look at the positive side. Are we making some progress, and are we helping some patients here, and are we getting better each time? And I think that probably is the case when we look at our more early experience in terms of just technical success. Do we actually do the operation successfully? Because certainly we fail sometimes. If you look at our early experience up to 2008, we certainly had quite a significant number of technical failures. It doesn't mean the baby doesn't survive, it's just that we're not able to open the valve and we have to let the baby be born with hypoplastic left heart. And certainly more recently, we have very few technical failures. So at least we've done better on the technical aspect of the operation. When you actually look at the outcome of the patients, again, in the early experience, more failures and more hypoplastic left heart. We did have some patients. Of course, only about a third of these patients ended up with 2 ventricles. Not good enough. If we look at our more recent data, we have very few failures again, and many more patients now with 2 ventricle circulation. So again, we're doing better at what we're trying to do. When you look at the overall outcome of patients that had a successful procedure or not, certainly the goal is to have a biventricular or 2 ventricle circulation. We are certainly doing much better with that. I'm now going to shift gears to the other form of hypoplastic left heart, which is hypoplastic left heart with what we call an intact atrial septum. You've all heard of a PFO, or patent foramen. A fetus is supposed to have a hole in the upper chambers that allows blood to flow from the right to the left side, brings blood from the placenta to the left side. In hypoplastic left heart, it has a different role, and it is important to decompress flow. Because the left side of the heart is small, the blood flow from the lungs has to empty across this hole into the right ventricle and go out to the circulation. The worst form of heart disease that we have is where this hole in the upper chambers is closed. When these babies are born, blood cannot escape from the lungs and go into the circulation, and those babies can't survive unless they have an emergency procedure if they get there in time. And so we came up with a procedure to try and improve things. There's much literature on this topic showing that this is us reporting this procedure, and also a lot on the natural history and how poorly these kids do. And this is what they look like. They have abnormal Dopplers in their pulmonary veins. Maybe you can just click on that button just to say later. It's giving me some update check there. There you go. Thank you. And so what we do in these cases is we actually stick a needle through the atrial wall, through the atrial septum, and blow up a balloon or place a stent, a coronary stent, just like in adults. This is what it looks like, a needle coming through the fetal lung, through the heart, and then puncturing the atrial septum. The balloon is then inflated, and there you go. So there was no flow before, and now the lungs are able to decompress, improve the circulation. When these babies are born, they can be more stable, don't need an emergency procedure. They still often have very abnormal lungs, so it's a very serious heart problem. Our biggest challenge here has been that these holes sometimes don't stay open, the tissue is very thick, and so we came up with a way to perhaps improve things by putting a stent in. And so this is just a cartoon that I drew, and what the plan was to place a stent. This, again, is a coronary artery stent, and this is what this looks like. A needle is placed across the septum, and then we place a balloon that has a stent on it, just like when you're having a coronary stent, and we open up the stent. In this particular case, the balloon actually burst. It's just saline filled, and in this case, the baby actually got heart block. You can see how slow the heartbeat is. After this procedure, we've put a big metal stent in the baby's heart. This is a 23-week fetus, I believe. We gave some epinephrine, atropine, and the baby's heart recovered very quickly. And here you can see the flow beautifully through the stent. This kid is now about 4 years old. So in the future, we have some challenges, of course. Again, optimally selecting our patients, improving technical aspects, the equipment. No one's making equipment for these procedures. We're using existing stuff because it's such a small amount of patients. Obviously improving our postnatal management and dealing with the politics of these complicated situations and how many institutions actually do these. There are several centers doing these procedures now, and again, it's always a challenge of who should be doing it, how many centers should be doing it, how do you develop expertise. There's a learning curve, and also improving detection, convincing our colleagues that we're making a difference, getting them to refer the patients, and of course, us always being very critical of our own data, looking at it carefully, doing careful research, and always trying to improve. This is a group of people that are involved. You may know some of them. And it starts with our fetal center nurses, social workers, anesthesiologists, obstetricians, the surgeons who help us postnatally with these patients. So everybody really has a role here. And that's an old picture of some of the members of our team. That's Louise Wilkins, who is our obstetrician, and Donna Morash, who's the nurse in our fetal center. That's me when still had brown hair, and Audrey Marshall and Jim Locke is our chief. And some other people up here. So thank you for your attention. I'm happy to answer any questions.